Welcome to the Hospital Medicine Unplugged podcast. We are undertaking a deep dive today into a critical metabolic complication frequently seen post-surgical intervention in our hospitalized patients, hungry bone syndrome.
Yes, HBS. And this syndrome, it's really far more than just your standard postoperative hypocalcemia. It represents a rapid, profound, and importantly, prolonged electrolyte derangement that demands immediate attention. Critically, it significantly impacts patient morbidity, drives high resource utilization, and it's often a major reason for a prolonged hospital stay.
So our mission today is really to unpack the pathophysiology behind this phenomenon, identify which patients are walking into the OR with the highest risk, the ones with that biggest mineral debt, so to speak, and outline the aggressive, sustained management protocols we need to navigate this challenge effectively at the bedside. Let's start right there with the core definition. When we talk about postoperative hypocalcemia, what specific criteria elevate that diagnosis to the severity of hungry bone syndrome? What defines this state?
Right. So HBS is defined by a constellation of findings, but primarily it's characterized by rapid, profound, and prolonged hypocalcemia. And crucially, it needs to be both severe and sustained. This clinical state is almost always accompanied by hypophosphatemia and hypomagnesemia. That's a really telltale triad. The whole derangement results from an abrupt, massive shift of calcium and other minerals into the skeletal system.
And that severity threshold is important, isn't it? It's not just a minor dip we might see after, say, a routine thyroid procedure.
That's exactly right. To meet the diagnostic criteria for HBS, the hypocalcemia needs to be significant. Typically, we define that as a serum calcium less than 2.1 millimoles per liter, or roughly 7.5 milligrams per deciliter. But the really critical distinction, the thing that separates HBS from less complex post-op issues, is that this severe hypocalcemia must persist for more than 4 days after surgery. That persistence really highlights the depth of the underlying metabolic deficit.
Okay. And surgically, what are the main clinical contexts where we're most likely to encounter this syndrome?
The vast majority of cases occur following parathyroidectomy. This surgery is usually done for one of two primary conditions, either secondary hyperparathyroidism, SHPT, which we see most often in chronic kidney disease patients on dialysis, or primary hyperparathyroidism, PHPT. These are the primary contexts because they involve the abrupt removal of the source of chronically excessive parathyroid hormone, or PTH.
You mentioned less common scenarios too, like thyroidectomy. Can you elaborate a bit on that context?
Yes, we do see HBS, although less frequently and usually less severely, after total thyroidectomy in patients who had significant preoperative thyrotoxicosis. The key there isn't actually the removal of the parathyroids, but the fact that chronic thyroid hormone excess itself is a powerful stimulator of bone turnover. So if those patients already had low preoperative bone mineral density, say vertebral osteoporosis, that high baseline turnover means their skeleton has built up a kind of mineral debt, and that debt suddenly demands repayment once the excessive thyroid hormone source is gone. The common denominator across all these causes is that the patient entered surgery in a state of high pathological bone turnover.
That name, hungry bone syndrome, is quite evocative. It suggests the skeleton is literally starving for minerals. Could you walk us through the rapid metabolic transition that creates this huge and acute mineral deficit in the serum?
It's really fascinating how quickly the switch flips. If you think about the patient before surgery, they had chronic elevated PTH. This PTH was pathologically stimulating osteoclasts. Those are the cells that break down bone. So this constant osteoclastic activity was essentially leaching calcium and minerals out of the skeleton and into the circulation, trying to maintain serum calcium levels. This is how the skeleton accumulates that massive mineral debt you mentioned.
So the bone was acting as a continuous, although pathological, source of minerals for the blood, all driven by PTH.
Precisely. Now, when the hyperfunctioning parathyroid tissue, the source of that excess PTH, is surgically removed, there's an immediate and abrupt stop to that PTH-driven signal for bone resorption. That signal to break down bone just stops cold.
But the body's natural bone-building cells, the osteoblasts, they're still active, right? Does this mean they just keep working but now unopposed?
That is the absolute critical pathophysiological mechanism. The osteoblastic activity, the cells building new bone, they don't shut off immediately. In fact, in a patient who had chronic high turnover, these cells might be highly sensitized, extremely active. So with the resorption rate suddenly plummeting, the osteoblasts continue forming bone. But now they have easy access to an ample supply of minerals from the circulation. The previously demineralized skeleton, holding that immense mineral debt, instantly begins a rapid and aggressive phase of remineralization.
It sounds almost like a bony creditor suddenly demanding immediate repayment of the debt.
That's a great analogy, actually. The bone starts furiously paying back its debt by rapidly pulling circulating calcium, phosphate, and magnesium into the bone matrix. This profound and aggressive uptake is what instantly and severely depletes the serum levels of all three electrolytes at the same time. It's really sequestration, not a lack of supply, that drives the acute deficit.
That mechanism really clarifies why we see that characteristic triad, a hypocalcemia, hypophosphatemia, and hypomagnesemia. All three minerals are just moving en masse into the bone because of this unopposed osteoblastic drive. Okay, so given that the severity of HPS is directly tied to this accumulated mineral debt, where should we focus our risk assessment? Which patients are walking around with the biggest debt, making them most susceptible to severe refractory HPS?
Right, if we connect this to the bigger picture, HPS risk is overwhelmingly centered on the underlying cause and the severity of the bone disease before surgery. It is far more common and usually much more severe in secondary hyperparathyroidism, SHPT, particularly in those chronic kidney disease patients who've been on long-term dialysis.
And the incidence rates in that SHPT group can be quite high, sometimes almost half of patients undergoing surgery, right? What specific metrics define a high-risk SHPT patient?
Yes, the incidence in SHPTs reported anywhere from 27 up to maybe 48% after parathyroidectomy. For these patients, the key predictors are those lab markers that reflect the high bone turnover state, specifically a high preoperative PTH level and a high alkaline phosphatase, or ALP. For instance, some studies might define high risk using cutoffs like a PTH level greater than, say, 1,000 picograms per milliliter, and an ALP exceeding 500 units per liter. These values really reflect profound renal osteodystrophy and that resulting mineral debt.
It's not just about the lab numbers, though, is it? The patient's history must play a role. What other demographic or disease factors increase the risk in the CKD population?
Absolutely. Other risk factors include younger age and a longer duration on dialysis. Both tend to correlate with more entrenched chronic hyperparathyroidism. Also critical is the total weight or volume of the parathyroid glands removed during surgery. A larger total resected gland volume confirms a higher overall disease burden and more extensive pathological turnover. Given this complexity, there are actually sophisticated predictive risk scores developed specifically for SHPT patients. These often incorporate PTH, ALP, age, and how long they've been on dialysis to formally stratify who really needs aggressive pre- and post-operative preparation. We also sometimes look at specific markers like osteocalcin, which has been independently identified as a predictor, reflecting that active bone formation happening even before surgery.
Okay, now switching gears to primary hyperparathyroidism, PHPT. The incidence is lower there, but we certainly can't ignore the risk, especially in the more severe presentations.
Correct. The incidence in PHPT is generally lower, maybe in the range of 0 to 17%. However, the risk definitely escalates significantly in patients who present with severe preoperative hypercalcemia and very high PTH levels. We also pay close attention to anatomical findings, things like the presence of large adenomas or glands, sometimes exceeding 5 grams in weight. And crucially, any radiological evidence of severe bone disease, like osteitis fibrosis cystica, that's a major red flag. It indicates the skeleton has been leached of minerals for a long time, guaranteeing a larger debt repayment after surgery.
What about vitamin D status? Does that consistently predict HPS risk in the PHPT population?
You know, it's often cited, but the evidence is still somewhat inconsistent. While treating severe vitamin D deficiency beforehand is generally good practice, relying on it solely as a high-risk predictor for HPS, specifically in PHPT, hasn't proven consistently reliable. For PHPT, the key clinical indicators really remain those severity markers, the magnitude of the PTH and calcium elevation, and any visible evidence of bone damage before the operation.
And finally, let's touch on that unique group again, total thyroidectomy for thyrotoxicosis. How does the risk profile differ there?
Right. In that specific setting, we're looking for evidence of high bone turnover that was caused by the excess thyroid hormone itself. The risk is elevated specifically in patients who have low preoperative bone mineral density, may be confirmed by a DXA scan showing vertebral osteoporosis, coupled with an elevated preoperative ALP. It's important to stress, though, that this phenomenon is almost exclusive to the hyperthyroid patient undergoing thyroidectomy. A patient having surgery for a benign nodule who is euthyroid doesn't carry this specific HPS risk.
Okay, so as hospitalists, when that patient comes back from the operating room, What are the immediate red flags we need to be looking for, both clinically at the bedside and on the lab panel, to rapidly identify HBS and not mistake it for simpler complications?
Clinically, we need to be highly attuned to the rapid onset of neuromuscular symptoms. That's the immediate consequence of the sharp drop in free ionized calcium. These symptoms can start within hours, certainly within the first day or two post-op.
And what are the typical things patients might report or signs you might see?
Patients often start with perioral tingling, maybe tingling in their fingers and toes, paresthesias. This can quickly progress to severe muscle cramps, carpopedal spasms, and potentially those classic signs of latent tetany like Shostak's or Trousseau's signs if you test for them. In unmanaged cases or with extremely rapid drops in calcium, this can unfortunately accelerate to frank tetany or even generalized seizures. And furthermore, that rapid remineralization process itself can be symptomatic. Patients might report significant diffuse bone pain or worsening muscle weakness, especially common in the SHPT group.
And biochemically, how do we confirm this is truly the debt repayment syndrome, HBS, versus just standard postoperative disturbances?
Well, the defining lab findings start with that persistent severe hypocalcemia. Remember, meeting that criterion of lasting more than 4 days is key. But the true biochemical hallmarks, the signature, is the simultaneous presence of hypophosphatemia and hypomagnesemia. The entire supply line, calcium, phosphate, magnesium, is being drained into the bone matrix at the same time.
And thinking about bone activity markers, what does the serum ALP typically do in the days following surgery in HBS?
The serum ALP characteristically begins to rise rapidly postoperatively. It often peaks around 2 weeks after the surgery. This biochemical trend is essentially confirmation of that intense, increased osteoblastic activity we discussed earlier. That rise in ALP is the laboratory proof that the skeleton is aggressively consuming minerals.
Given the rapid and sometimes profound nature of the hypocalcemia, particularly thinking about its effects on myocardial function, how intensely do we need to monitor the cardiac system in these high-risk patients?
Oh, intensive cardiac monitoring is absolutely critical. Severe hypocalcemia carries a direct risk of QTC prolongation on the ECG. If that QTC interval stretches out significantly, the risk of a life-threatening ventricular arrhythmia, like torsades de pointe, increases dramatically. Therefore, continuous ECG monitoring is really non-negotiable, especially when calcium levels are still falling or remain severely low in those first few critical days. We have to be ready to aggressively replete calcium immediately if we see any symptomatic hypocalcemia or significant QTC changes.
Okay, this is a really crucial diagnostic point. Postoperative hypocalcemia, particularly after neck surgery like parathyroidectomy or thyroidectomy, immediately makes us think about potential parathyroid gland injury first. How do we use our initial lab work, maybe in those first 24-48 hours, to reliably distinguish HBS, this mineral debt problem, from true postoperative hypoparathyroidism, which is more of a hormone insufficiency problem?
This is probably the most important clinical distinction to make right up front, because while both conditions present with hypocalcemia, the underlying issue, and therefore the management strategies, are fundamentally different. The key differentiators lie in the status of the remaining parathyroid function and consequently the serum phosphate and magnesium levels.
Let's just quickly nail down that core pathophysiological difference again.
Right, so hypoparathyroidism results from PTH insufficiency. The glands were injured, maybe accidentally removed, or perhaps their blood supply was compromised during surgery, leading to insufficient hormone output. HBS, on the other hand, occurs after a successful surgery where PTH levels are intentionally abated because the source of the chronic excess PTH was removed. This abatement then allows that skeletal debt repayment process to kick into high gear.
Okay, but if both conditions can result in a low PTH level immediately postoperatively, how does measuring PTH actually help us differentiate in that common scenario after parathyroidectomy?
That's a great point. If the patient underwent parathyroidectomy for hyperparathyroidism, the PTH should be low or suppressed if the surgery was successful and curative. So in that specific context, a low PTH doesn't reliably differentiate the cause of the hypocalcemia. However, think about the less common scenario. HBS occurring after total thyroidectomy for thyrotoxicosis, where the parathyroids were hopefully left intact. In that situation, PTH levels might actually be normal or even elevated, showing the glands are still trying to respond to the low calcium. Seeing a normal or high PTH clearly rules out hypoparathyroidism as the cause of the hypocalcemia. But the real clinical pearl, the immediate differentiator available on most basic metabolic panels, is the phosphate and magnesium profile.
This is where we need the most clarity. Can you contrast the typical electrolyte profile of HBS versus classic post-op hypoparathyroidism side by side?
Absolutely. In HBS, the patient presents with hypocalcemia, but it's critically coupled with hypophosphatemia and usually hypomagnesemia. Remember, all three minerals are moving into the bone matrix. Now, in isolated postoperative hypoparathyroidism, you also have hypocalcemia, but crucially, you will almost always see hyperphosphatemia.
And why the hyperphosphatemia specifically in hypoparathyroidism?
It's due to the lack of PTH action on the kidneys. PTH normally acts on the renal tubules to increase phosphate excretion. When PTH levels are low or absent, the kidney retains phosphate, leading to hyperphosphatemia in the serum. Furthermore, magnesium is usually normal in isolated hypoparathyroidism unless there happens to be a coexisting deficiency for another reason. So finding low calcium together with low phosphate is really pathognomonic for a massive mineral sequestration. That's hungry bone syndrome.
And the ALP trend provides that final piece of biochemical confirmation, reflecting the underlying metabolic acceleration, right?
Exactly. The ALP, alkaline phosphatase, is essentially the footprint of the osteoblast activity. It's typically elevated, often rising postoperatively in HBS, confirming that high bone turnover state and the active remineralization process. In simple, isolated hypoparathyroidism, ALP is usually normal or perhaps only mildly elevated because there isn't that underlying pre-existing high bone turnover driving things. So putting it all together, persistent hypocalcemia with low phosphate and low magnesium coupled with a rising ALP that is the biochemical signature of HBS.
Okay, given the potential severity, the need for prolonged care, and the high resource utilization these patients can really take up valuable acute care beds for a long time, we clearly need an aggressive and sustained management approach.
Yeah.
How do we structure the acute and then the more chronic phases of therapy?
Yes, the management has to be intense and, frankly, relentless. We need to focus on aggressive and proactive mineral replacement. You almost have to think of it like funding an aggressive debt repayment plan that might need to continue for weeks, sometimes even months.
Starting with the acute phase, the firefighting calcium replacement, how do we approach IV therapy, especially in that very high-risk SHPT patient who might need it for a prolonged course?
Calcium replacement is absolutely the cornerstone of management. Intravenous calcium gluconate is mandatory for any severe or symptomatic hypocalcemia. For the highest risk patients, particularly those with severe SHPT and very high preoperative turnover markers, it's common practice and often necessary to initiate a continuous IV calcium infusion immediately post-surgery, rather than relying solely on intermittent boluses. These infusions need meticulous management. We're often titrating the rate hourly based on frequent ionized calcium levels. And it's not unusual for these infusions to be required for several weeks because the bone's hunger for calcium is just so profound.
And once the patient is more stable, the transition to oral therapy requires really massive doses, doesn't it? What kind of scale are we talking about?
We have to transition to high-dose oral calcium, usually calcium carbonate or sometimes citrate, as soon as the patient can tolerate oral intake. And yes, I mean high dose. We often require total daily elemental calcium intake that routinely exceeds 3 to 6 grams. Just for context, a typical supplement dose might be 1 to 1.5 grams per day. Here, we're frequently pushing doses several times that magnitude. And these doses need to be meticulously titrated, usually aiming to keep the serum calcium in the low normal range, ideally between 8.0 and 8.5 milligrams per deciliter, or 2.0 to 2.1 millimoles per liter.
If a patient's calcium levels remain stubbornly low despite these very high oral and IV doses, are there any other adjunctive therapies we can consider?
Yes, in particularly refractory cases, we sometimes utilize strategies like adding a thiazide diuretic. Thiazides work by reducing urinary calcium excretion in the distal tubule. This acts as a calcium-sparing maneuver, helping to maintain the serum level by preventing losses via the kidney. Of course, this assumes the patient's renal function allows it, and there are no other contraindications.
And active vitamin D is essential here too, I imagine, because we need to maximize every bit of calcium absorption from the gut that we possibly can.
Absolutely essential. Early initiation of active vitamin D analogs, calcitriol or perhaps alpha-calcitrol, is critical. Calcitriol typically starts at doses around 0.5 to 2 micrograms per day, often given in divided doses, like twice daily, and must be aggressively adjusted based on frequent monitoring of serum calcium levels. We prefer the active forms like calcitriol because they bypass the need for renal or hepatic hydroxylation steps, directly maximizing intestinal calcium absorption and also actively facilitating that bone remineralization process. If there's also a pre-existing deficiency in vitamin D storage, cholecalciferol, vitamin D3, might also be added concurrently, but the calcitriol is really for the acute metabolic control.
We discussed magnesium earlier as part of the diagnostic triad. Why is correcting hypermagnesemia so critical, even when our primary focus seems to be on the calcium level?
Magnesium correction is paramount. It's absolutely crucial because hypomagnesemia directly impairs the entire calcium regulatory system. Low magnesium levels inhibit the secretion of PTH from the remaining or recovering parathyroid glands, and it blunts the peripheral action of PTH on its target tissues, like bone and kidney. So if you don't correct the magnesium deficit first, your aggressive calcium supplementation will simply be less effective, and the hypocalcemia will remain refractory. We must aim to bring the serum magnesium level into the mid-normal range using immediate oral or, if necessary, intravenous replacement. It's often the rate-limiting step in resolving the calcium deficit.
Okay, and finally, let's talk about the phosphate strategy. This seems counterintuitive compared to standard post-op hypoparathyroidism, where we might restrict phosphate. Here, we typically see hypophosphatemia.
Right. In HPS, phosphate restriction is generally contraindicated. Hypophosphatemia is expected. It's part the syndrome as phosphate rushes into the bone alongside calcium. We must actually avoid aggressive phosphate supplementation unless the patient develops severe symptomatic hypophosphatemia, which is relatively rare. The risk is that if you actively replace phosphate, you're essentially just giving the hungry bone more fuel, which can paradoxically worsen the hypocalcemia even further by accelerating calcium and phosphate co-precipitation into the bone matrix. Maintaining the calcium and magnesium levels is the priority. The low phosphate is more of a physiological indicator confirming the HBS state.
And managing all this complexity clearly requires nonstop monitoring. What does an intensive monitoring protocol typically look like for these patients, especially early on?
Intensive monitoring is absolutely non-negotiable, particularly in the first 1 to 2 weeks postoperatively. Serum calcium, both total and ionized, along with phosphate, magnesium, and ALP, must be checked at least daily initially. For the most severe patients, especially those on continuous IV calcium infusions, ionized calcium often requires checks every 4 to 6 hours around the clock. These frequent checks should only be spaced out gradually, maybe to every other day or less frequently, once sustained biochemical stability is achieved. And stability means maintaining serum calcium consistently in that target low normal range without needing to increase the IV calcium rate or the oral supplement doses.
So after we initiate this intense, often multidisciplinary regimen, what's the expected clinical course for these patients? And what are the real, tangible implications for hospital length of stay and the demand on our resources?
HPS typically develops quite rapidly, within hours to days post-op, but the course of recovery is often protracted. While the ultimate prognosis for full recovery is generally excellent with appropriate and diligent management, the condition is definitively associated with significant resource utilization. This includes longer average hospital stays, often adding days, sometimes weeks, to the admission. And it can necessitate prolonged stays in the ICU for that continuous IV calcium management and close monitoring, particularly in the most fragile CKD patients.
How does the duration of this hungry state typically differ based on the underlying reason for the surgery, like SHPT versus PHPT?
The duration is highly dependent on the magnitude of that preoperative mineral debt. It is generally longer and more severe in SHPT patients on dialysis. These individuals can require sustained, high-dose calcium and active vitamin D supplementation for weeks, sometimes even months, after their parathyroidectomy. In PHPT, the hypocalcemia typically lasts for a shorter period, often days to maybe a few weeks, resolving much faster because the underlying bone disease is generally less severe and less systemic than in advanced renal osteodystrophy.
So it sounds like the duration of recovery is almost a direct mirror of the severity of the preoperative bone disease we talked about identifying earlier.
Exactly. The larger the mineral debt going into surgery, the longer the repayment period will be coming out of it. In rare, very complex cases, like patients with underlying conditions, such as X-linked hypophosphatemia who undergo parathyroidectomy, or those with parathyroid carcinoma causing severe bone disease, they might require continuous mineral supplementation for many months. However, the ultimate outcome, long-term, is usually favorable. With timely and aggressive management, patients achieve normalization of their electrolytes and resolution of their symptoms. And importantly, their bone mineral density eventually restores itself over the long term. Our vigilance in the hospital is primarily focused on preventing those acute major complications like tetany or life-threatening arrhythmias during that immediate vulnerable postoperative phase.
This whole deep dive really highlights that successful management of HBS hinges crucially on recognizing that high-risk patient, the one with the very high PTH, the high ALP, evidence of severe underlying bone disease, ideally before they even leave the operating room. That anticipation seems key.
Precisely. Preemptive identification allows for proactive, immediate supplementation strategies and justifies that intense level of monitoring right from the start. These interventions are really the only way we can effectively prevent significant morbidity and mitigate that predictably prolonged hospital stay. And crucially, always remember that diagnostic pearl. The distinction between HBS and simple hypoparathyroidism is reliably made based on that signature combination of hypocalcemia with hypophosphatemia and hypomagnesemia. That directs us to treat an underlying mineral debt problem, not merely a PTH insufficiency problem.
So synthesizing everything we've discussed today, the risk factors, the underlying mechanism, the diagnostic clues, and these aggressive management protocols, what does this all really mean for us at the bedside when we're managing these high-acuity surgical patients?
I think the key takeaway is that when you encounter postoperative hypocalcemia in a high-risk patient, especially after parathyroidectomy for SHPT or severe PHPT, it requires a sustained and aggressive approach. It demands mineral repletion protocols that fully acknowledge the patient's skeletal system has amassed an enormous mineral debt, one that requires potentially weeks or months to fully repay. You're not just giving a simple electrolyte dose, you're essentially funding a long-term skeletal recovery project. And the final thought for you to consider, perhaps moving forward, is this. In this era where we have increasingly sophisticated predictive risk scores, particularly for SHPT patients, how might we better integrate proactive strategies? Could we potentially use high-dose oral calcium and active vitamin D protocols preemptively in identified high-risk individuals, maybe even starting them several days before surgery, to possibly blunt the severity and shorten the duration of HBS postoperatively? Could this potentially reduce the need for those costly, prolonged IV infusions and ultimately lessen the overall burden on the patient and the hospital system?